Welcome everyone to the meeting. We are going to revise the 3 cancers of today: cancer endometrium, cervical cancer, and ovarian cancer. So for the cancer endometrium, we are going to review the staging and the main line of treatment of the staging according to the 2023 update. I would like to start with you, my friends, with here, okay, trying to show you the staging and to understand the principles behind the staging. So, my friends, whenever we are removing a part from the body, right, what we do, we send it to the histopathology, correct? Right? So, there is what we call it a macroscopic picture or a description to the lesion. So I can say, for example, this lesion invades 30% of the myometrium, right? This is my description, the gross picture, right? And then the histopathology is going to have a deeper look, and they are going to tell you that this is adenocarcinoma, for example, this is endometrioid carcinoma, this is sarcoma, or whatever, correct? But now, what we are saying that it is a trend nowadays that we have to have a further look, okay, into the histological grading. And the histological grading give us an idea about the behavior of the cells. Okay, so if I told you there is a well-differentiated tumor, what do you understand about this? Well-differentiated tumor. It has, yes, not aggressive tumor, okay, and it has a good prognosis, correct? Yes, well done. How about if I told you that there is poorly differentiated tumor? So poor is aggressive type. Yes, excellent, excellent. Okay, so nowadays, they don't only give you the surgical staging of the tumor, but also they have included the histological grading. And even more, they have included what is called the molecular profiling. Yes, excellent. What is this molecular profiling? If you study the guideline, you will find that there are recommendations that we test all the samples by the immunohistochemistry, trying to get a link between the cancer and the presence of abnormal or faulty genes. And by understanding or identifying, okay, the faulty gene, you will get an idea about the behavior of this tumor. So for example, okay, we will have the POOL mutation or the P53 mutation or the MMR, this is for Lynch syndrome, or the non-specific type, right? So if I told you that most likely POOL mutation are well-differentiated tumors and they have good prognosis, what do you understand about this? You would understand that this type of tumor behavior is not aggressive. This is one thing. Another thing that maybe in early stages, okay, especially if it's a confined tumor, I don't need to add therapy like radio or chemotherapy, correct? So those are the principles. Those are the principles and the background why they have changed the figure classification now in the 2023, because they are trying to include, as I told you, more information about the behavior of the tumor. Clear? Not only the surgical staging or the anatomical description. So let's see, what is a stage 1 in endometrial cancer nowadays? Stage 1 is a confined to the uterine corpus or the ovary, and we will discuss, okay, the point of the ovary. It comes, okay, because this is special for the endometrioid tumor. So 1A is now subdivided into 1A1, 1A2, and 1A3, where in 1A1, it's a non-aggressive histological type. So my friends, especially my friends in the course who joined me yesterday, very important to remember, very early stages, this is kept for what? For good behavior, right? Tumors, right? Not the naughty one. It's the good behavior. Yes. So non-aggressive histological type, but it's limited to the endometrial polyp, only polyp, okay? Or confined to the endometrium. Okay, so now 1A1 is only if this is the uterus and this is the endometrium, okay? So here the tumor will be only confined to the endometrium. No myometrial invasion or a polyp, okay? And it's a non-aggressive type, right? Okay, this part understood, my friends? 1A1, if there is any problem in understanding 1A1, polyp or confined to the endometrium. No myometrial invasion and non-aggressive. This is the most important thing here. All clear? Okay, so how about 1A2? In 1A2, the myometrial invasion started, but it's a non-aggressive also type. So 1A2 is non-aggressive histological type, involve less than half of the myometrium. Okay? And of course, no or focal lymphovascular invasion. What is the lymphovascular invasion? It's the invasion of the tumor to the nearby lymph vessels and capillary. Okay? We consider it no when there is no lymphovascular invasion at all. And the focal means that less than 5 vessels involved, small vessels, or it is significant or substantial lymphovascular invasion if it is more than 5 vessels involved. So what is the importance of this? When I tell you that the tumor have no lymphovascular invasion, is that a good sign? Yes, of course. Yeah. Yes, because actually the primary spread of the endometrial cancer comes by the lymphatics. So if no lymph vessels involved, then it's fine. We are confined now into only these local cells. Okay? Okay. So a non-aggressive, less than half of the myometrium with no or local lymphovascular invasion. 1A3 is a special stage in this staging. What is this? This is for low grade also, but it's endometrioid carcinoma, not adenocarcinoma, endometrioid carcinoma. And my friend, endometrioid carcinoma can come from the ovary and the uterus or only uterus. Yes, yes. So that's why here it's a low grade endometrioid carcinoma limited to the uterus and ovary. Okay, so this is a special. So when you see endometrioid nowadays, what you will say? A1, A3, 1A3. If it is limited to the uterus and ovary, it doesn't matter 30%, 50%, more than 50, since it's only limited to the uterus and ovary, not spreading anywhere else, then it's 1A3 because it's endometrioid. Okay? How about 1B? 1B is non-aggressive again. Histological type with invasion of half or more of the myometrium. Okay, this is similar to the old staging. So here, this is the uterus again. And this is the myometrium. Then I told you that the tumor here and it invades 50% of the myometrium. Which stage is this? If this is non-aggressive histological type. Which stage is this? 50% or more. Non-aggressive histological type. 50% of myometrial invasion or more. 1B. Excellent, Dr. Sarah. Excellent, Dr. Fatima. Okay, wake up, wake up. So this is like the old one. So we are happy for it. Okay, so what is the 1C? Doctor, I remember there was no C in the older stages. Yes, C is new in this staging. So 1C, I would like you to remember that C is for aggressive. There is no C in aggressive, but I will try to link it anyway, okay? So C for aggressive type, C for aggressive type. So 1C is for aggressive histological type. What is this aggressive type? The aggressive type, remember, they are the naughty tumors, okay? So they behave aggressively with high risk of recurrence, right? So that's why 1C is aggressive type, but very, very small, limited to a polyp or confined to the endometrium. So do you remember this image that I show you, or this drawing, sorry, and excuse me guys for the horrible drawing. This is the endometrium, and we have here the aggressive type here. It's confined to the endometrium, but it's aggressive. So what I will call this stage. What I will call this stage, aggressive but confined to the endometrium or a polyp. 1C, excellent. So look, my friends, what happened? Look, the significance of, or the difference of the histological grading or knowing if there is any gene that can make the tumor behavior aggressive like P53 abnormality, okay, can turn the case from 1A1 staging to 1C, can turn the management from no adjuvant treatment required like in 1A1 to 1C. And you know what is 1C? C for aggressive, C is for CCRT. So you will make the surgery, and after the surgery, the patient will need combined radio chemo. All of this because of the tumor behavior, right? So I'll tell you a situation that might happen in real life. So you are having a patient which is diagnosed by endometrial cancer. You have done ultrasound, MRI, and everything, and it's just a small foci here, confined to the endometrium, this part. Okay? Nothing else abnormal so far. Okay? So, you discussed with her the management, and then you undergone the hysterectomy procedure, right? Okay, so you have done hysterectomy with bilateral secondary ovarectomy, send it to the lab, and the lab result comes saying that the histological type is aggressive. It's a poorly differentiated tumor. It's an aggressive tumor. So from just reassurance, now you have to call your patient to tell her about the next journey in her treatment, what we call it adjuvant treatment. The patient will not only receive chemo, she will receive chemo and radio, external beam radiation plus chemotherapy. Okay, so excellent, Dr. Dina, excellent, Dr. Sarah. So you can see here, how did this change? We changed a lot, right? Based on what? Yes, Dr. Aisha, even if you removed the whole uterus already, that's because the tumor aggressive. So any cells remained here or there, skip to the lymph vessels or anything, it can, okay, make a metastasis and it can have risk of recurrence. So that's why we will have to fight it, okay? You have to contain it with the CCRT. Okay, my friends? So you can see how the grading makes a big difference in the management now. It used to give us a difference in the management, but not that, clear idea about every stage, what to do, and so on. Okay, so if we just revised, we will just, okay, revise the stage 1, and then we move to the stage 2. For stage 1, again, 1 is subdivided into 3, 1A, 1B, 1C. 1A is again subdivided into 3, 1A2, 1A1, 1A2, 1A3. 1A1 is a very small tumor confined to a polyp or endometrium, non-aggressive histological type. This is the most important thing. 1A2, it's a non-aggressive also histological type, but involve less than half of the myometrium. And of course, there is no substantial lymphovascular invasion. 1A3 is a special one. It's for endometrioid carcinoma, limited to the uterus and ovary. 1B is non-aggressive, but invasion of half or more of the myometrium. This is 1B. 1C for, so today I want you to finish the class and you remember. 1C is for, C for aggressive. Excellent, Dr. Fatima. And C is also for CCRT. Okay, so I want you to remember this information. Only when you see 1C in the exam, you know what to do. Okay, so it's aggressive, but small. It's confined to a polyp or the endometrium. Yes, even if it's that small, but aggressive type, I'm afraid of the risk of recurrence. We will have to add adjuvant therapy. Okay? How about the stage 2? So I will use another color for stage 2. Blue. Okay, let's go for blue. Stage 2. This is invasion of the cervical stroma. So in the old days, we used to say invasion to the cervix or spread to the cervix, then finished. This is stage 2. No, nowadays we have, in the new staging, we have 2A, 2B, 2C. 2A is invasion of the cervical stroma, but it's non-aggressive histological type. So remember, always A is the kind man here. Good behavior tumor. 2A, 2A, 2A. 2 means that it reached cervix. Okay? Second part. And it's a non-aggressive. A, because it's a non-aggressive. Okay? This is a good behavior tumor. 2B is substantial lymphovascular invasion of non-aggressive histological type. So it's still non-aggressive, but there is substantial lymphovascular invasion. And substantial lymphovascular invasion, my friends, that means that 5 vessels or more, okay, are involved, lymph vessels. And here we don't speak about lymph nodes, we speak about lymph vessels. Means that start of spread. Okay? So once told you substantial lymphovascular invasion, even if it's a non-aggressive tumor, even if it's less than half of the myometrium, what you will say? Less than half of the myometrium, non-aggressive, but associated with substantial lymphovascular invasion. Now it's 2B. Yes, so the presence of substantial lymphovascular invasion makes the grading 2B. So you can see involvement of lymph vessels only. Small lymph vessels associated with upstaging of the tumor, right? So 2C, C4, aggressive. So I expect here I have aggressive tumor, aggressive histological type with any myometrial invasion. Okay, so in the older days, we used to say, if a tumor less than 50% of The myometrium, that's 1A, right? But nowadays, if it invades the myometrium and you discover that it's aggressive behavior type, what you will do? You will make it 2C. Less than 50, 50, more than 50, it doesn't matter. Since it's aggressive and associated with myometrial invasion, I give it 2C. Clear, everyone? I hope it didn't become complex. We'll try to make it easy, okay? The early stages is the important stages for your exam. Remember this one. Why? Because this is the stages where this can make a difference, this can make a difference. We can save here the organ, we can do this, we can do that, okay? So that's why, okay? Any aggressive is C, my dear, okay? So in the aggressive, since it's aggressive, I don't look to the lymphovascular invasion. Okay, Dr. Basma? It's aggressive, خلاص. So it means it will spread anyway. It's naughty, so we can't really predict its behavior. So my friends, the recommended standard surgical procedure for the treatment of early stage endometrial cancer is extrafacial total hysterectomy with bilateral salpingio-oophorectomy, correct? Right? Okay, so the adnexal removal also is recommended even if the tube and ovaries appear normal. Okay, this is for the maybe looking for micrometastasis. So, if available, this is a new one and feasible, the molecular classification testing, and this is, as we said, this is for the genes. For pole mutation, MMR, mismatch repair deficiency, or the non-specific molecular profiling, or the P53 abnormality, those are 4, okay? 4 tests, panel testing. This will be encouraged in all patients with endometrial cancer for prognostic risk group stratification. Okay? 1 and 2, Dr. iPhone 11. Okay? So, as factors that might influence the adjuvant and systemic treatment decision. Okay, so let's see if I have stage 1, low-grade tumor. What is the management? Tell me, my friend, please. Stage 1, well-differentiated. Well-differentiated is like low-grade, is like non-aggressive. Okay, so surgery. Do you need adjuvant treatment for stage 1 low-grade disease? No, it's a non-aggressive histological type. And yeah, okay, so simply surgery is enough. Well done. Okay, intermediate risk group tumors or moderately differentiated, we will add brachytherapy. So how I will know it in the exam? Simply, he will tell you. Okay? Okay, high-risk tumors, what to do with high-risk tumors? For high-risk tumor, it will be pelvic external beam radiation after the surgery or adjuvant to the surgery plus adjuvant chemotherapy. So this is like we have said before, the concurrent combined chemo radio. Sometimes people can make it sequential, no problem, okay? But it's a combination. This is what you need to remember. It's a combination between radio and chemo, okay? And this is for aggressive tumor type. Or if he told you poor differentiated, or if he told you grade 3 histological type. Okay? Clear, my friends? So just remember it for the early stages. This is the main management. Okay. How about the after that stage, stage 3 and 4? Okay, so it's easy, my friends. In stage 3, it's a surgery plus adjuvant, and the adjuvant is CCRT. So we have started CCRT from the 2C and we continue with it. Sometimes for a patient who is not fit for surgery, we can go for primary radio. Okay, so for stage 3, here, we complete the staging quickly. Here, there is no tricks. Why? Because simply finished. This is already stage 3, right? So here we don't speak about the tumor type or the tumor behavior. It's already spread, correct? So the ministry will be surgery plus adjuvant. Okay, so what is the stage 3? Stage 3 could be 3A, 3B, and 3C. This might be important for the staging equation. If he give you a staging equation and he told you the following tumor, according to the FIGO 2023 staging is stage, so you can choose. Okay? 3A is invasion of uterine cirrhosis, adnexia, or both by direct extension or metastasis. So I remember one of the recall questions says that the tumor was involving cirrhosis. So once we said that we are in 3A, right? So 3A is also subdivided into 3A1 and 3A2. Spread to the ovary or fallopian tube. This is 3A1. So this is adenocarcinoma, started in the uterus and then spread to the tube or the ovary. This is 3A1. In 3A2, this is involvement of the uterine subserosa or spread through the uterine serosa. So in exam, he can tell me the tumor that involves the serosa, and I have choice of 3A, which is correct. Or sometimes he can be more specific and give me the sub-staging, 3A2. Which one is more correct? First answer or second answer? Both are correct, but if you have to choose between them, which one you will go for? 2, well done. Okay. So 1 second, my friends. Thank you, my friends. And let's continue. 3B, what is 3B? 3B is metastasis or direct spread to the vagina. Okay, so if it is to the vagina and or the parametria is 3B1. 3B1. 3B2 is metastasis to the pelvic peritoneum. So just try to remember, okay? Vaginal spread. Upper part of the vagina, lower part of the vagina, it doesn't matter. This is 3B1, okay? So again, it can come in the question 3B only or can be more specific and be 3B1. Peritoneal involvement is 3P2. What is 3C? 3C, okay, as you can see, C is 6 substages, okay? Inshallah, it will not be that, much sophisticated in the exam. When they ask about the involvement of the pelvic lymph node or para-aortic lymph node. So 3C1 is pelvic lymph node. 3C2 is para-aortic lymph nodes, okay, up to the renal vessels. Clear, my friends? So you see in the question, pelvic lymph node involvement, what you will choose? Three C1. Okay. Para-aortic lymph node is even far. So it's 3C2. Level 2, yes. Stage 4. Stage 4 is spread to the bladder, mucosa, or intestinal or bowel mucosa. This is 4A. abdominal peritoneal metastasis beyond the pelvis. Okay, so not spread only to the pelvic peritoneum. This is beyond the pelvis. So abdominal peritoneum. This is far metastasis. This is 4B. 4C is distant metastasis. Okay, like metastasis to any extra or intra-abdominal lymph node above the renal vessels. Okay, and for example, distant metastasis to the brain, liver, lung, okay, or even the bone. So this is 4C. Okay, so can I treat 4C with surgery? No. So actually the management is mainly palliative, okay, and it can be radio and systemic chemotherapy. Are we clear so far, my friends? We have tried to make like quick notes, okay, to the staging of cancer. Okay, and here some applicable questions. And I have tried or collected some questions for you, dear friends. And these questions are like introduction to the endometrial cancer. And then we will have the staging and treatment questions, okay? Advanced stage, my dear, it will be surgical, okay, plus combined radio and chemo. If the patient is not fit for surgery or distant metastasis, so we can think about primary radio plus or minus chemo. Okay? It's like a big rule. Okay? Okay. So, my friends, okay, some easy questions coming. And let's say Bismillah, starting our mock. So, 65-year-old woman with BMI 40, early menarche, late menopause. So, 3 risk factors for endometrial cancer, right? BMI 40, early menarche, late menopause, and type 2 diabetes, 4 risk factor. Present with postmenopausal bleeding. Oh my God. The exit cervical cytology was normal. She had previously had a cone biopsy and known to have cervical stenosis. Ultrasound scan of her uterus revealed an endometrial thickness of 20. So 20 must be, this is a high-risk patient with thick endometrium, very thick actually. Both people biopsy in the clinic and general anesthesia hysteroscopy and the biopsy were unsuccessful due to cervical stenosis. So everything was not successful. I can't get the sample. What is her age? 65. Full of risk factors. So what further step would you discuss with the woman? Yes, I will discuss treatment by surgery, right? Because the only way to get the sample will be by the histopathology post removal of the uterus, right? Yes, well done, my friends. Well done, everyone. Okay. So here is another question. For a 50-year-old patient with BMI 20. Yes, Dr. Dina, my dear, because they have tried to take the people and they have tried to take the sample using hysteroscopy under general anesthesia, and it was not possible because of the cervical stenosis. How you will get the sample? She's already having postmenopausal bleeding. She is 65 and full of risk factors. Right? Okay. Next task. He didn't ask you what is the appropriate management. He's asking you what further step would you discuss with the woman. So it means that, okay, what you will counsel her about. Okay, so there is in the questions, my dear Dr. Basma, there is a leading, okay, word in the scenario. This is contain the instruction to you how to choose the answer. So sometimes it can tell you what is the next step in the management. Could be arranging investigation, okay? Sometimes can be what is the best investigation, what is the appropriate management. Now he's asking you about what you will discuss with the woman, okay? So the leading sentence in the scenario makes a big difference in the answer. Here, a 50-year-old with BMI 20 and one episode of postmenopausal bleeding present to the clinic. She's otherwise asymptomatic. So he's trying to, reassure you, okay, about the case. Abdominal and pelvic examination is unremarkable, and the endometrial thickness is 6 millimeter. Okay? Outpatient hysteroscopy and biopsy is arranged. The cavity is noted to be 8 in length, and adequate sample is taken. Endometrium was noted to be atrophic at the hysteroscopy, and the cavity is normal. At 2 weeks later, the histology report reads some inactive endometrium, but sample insufficient for diagnostic purpose. On reading the histology report, what would be the most appropriate action? So he is trying to tell you by many cues in the question, okay, that this is a low risk case. So the answer will be discharge the patient from the clinic and ask the GP to refer her again if she had any further episode. Okay? So the patient had the sample by the hysteroscopy, my dear. So I can't choose the hysteroscopy again. Investigation is done. So guys, investigation is done. So it was 6 millimeter. What happened after this? Yes, if this is a recurrent, she will come back again, of course. And we will do a biopsy if this is a recurrent. But this is, he told you this is one episode. Okay, biopsy is done. And it was outpatient hysteroscopy is done, okay? So what happened is atrophic endometrium at the hysteroscopy. So do you still think that arranging another hysteroscopy will benefit? No? Okay. If the patient had a further episode, so she will come back again, and we will, in this case, we can repeat the biopsy. Otherwise, if only one episode and atrophic endometrium, no, nothing to be done, especially in low risk patient. Here is a 60-year-old postmenopausal who is using tamoxifen for breast cancer. Tamoxifen is a risk, right? Present with history of postmenopausal bleeding. A transvaginal ultrasound showed an endometrial thickness of 6 millimeter. What is the best course of action? Guys, what you will do? Any patient on tamoxifen and complain of bleeding, it doesn't matter the endometrial thickness. What you will do? Yes, this is a hysteroscopy and biopsy. Okay? The patient already had personal history of cancer. She is on a drug that increases risk of cancer of endometrium. Yes, any bleeding must be investigated. Okay? Hysteroscopy and targeted biopsy. A 51-year-old present with 2 months history of postmenopausal bleeding. The period stopped the last year, and she had been using continuous combined hormone replacement therapy for 9 months now. Transvaginal ultrasound revealed a normal size anteverted uterus with normal ovaries and the endometrial thickness of 3. Clinical examination unremarkable. So what you will do? This is 2 months history of postmenopausal bleeding. Okay? but the patient had endometrial thickness of 3. What is the most appropriate management? Okay, so the patient on HRT, since she is on HRT and the patient found to have one bleeding episode, what I will do next? I will give a chance, right? Stop the hormonal replacement therapy, right? And investigate further if the symptom persists beyond the 6 weeks. Yes, and this is based on the TUG article. Okay, so nowadays in the guidelines, the new guidelines says after 4 weeks we can assess, but it's okay, 4 or 6 is fine. This is the only possible answer we have found here. Yes, correct. Yes, well done. Okay, so here, my friends, FIGO 2023 staging for endometrial cancer. Allocate them appropriately to the fourth clinical scenario. Okay, so the first scenario says a woman undergoes a total laparoscopic hysterectomy and bilateral salpingo-oophorectomy for a biopsy-proven endometrial cancer. The final pathology report describes an endometrioid carcinoma confined to the inner half of the myometrium. Peritoneal washing, however, positive. Peritoneal washing important in staging of cancer, endometrial cancer? No, it's not important in the endometrial cancer. Yes, for ovary. Excellent, Dr. Iman. Excellent, Dr. Farah. Okay, so what is the stage now? The key word here is endometrioid carcinoma, and it's confined to the uterus. So which stage is this from what we have learned? This is 1A3. This is a special one. Yes, 1A3. They made low-grade endometrioid carcinoma limited to the uterus and ovary. Well done, everyone. At the time of hysteroscopy, abnormal lesions were found in the uterus, at the cervix, and also on the upper portion of the vagina. MRI scan did not show any pelvic spread otherwise. Biopsy of this lesion showed adenocarcinoma, consistent with endometrial origin, upper portion of the vagina. 3A or 3B? Okay. So, answer is 3B. Yes. So here, my friend, we said in the stage 3, metastasis or direct spread to the vagina and or the parametria of pelvic peritoneum. So vagina and or parametria is 3B1. He didn't give you this specific, he only gave you 3B, so it is the answer. Okay. Non-aggressive endometrial cancer, which invade more than 50% of myometrial thickness. What is this? Non-aggressive endometrial cancer invade more than 50% of myometrial thickness. Yes, yes, of course. This is the 1B stage. Yes, it's non-aggressive and it's 50% of myometria or more. Remember, no or only focal lymphovascular image. Okay. Aggressive endometrial cancer, which invaded more than 50% of myometrial thickness. Okay. 2C. Well done. Well done. Yes, it's aggressive. Yes, 2C. Aggressive endometrial cancer confined to a polyp. Yes, it's 1C. Well done. Well done. Well done. Well done, everyone. Well differentiated endometrial cancer treated by simple hysterectomy and found to have large pelvic lymph node. So here, my friend, it was a tumor that we thought it's early stage. Even the histopathology told you that this is a well-differentiated tumor, but there was a large pelvic lymph node spread. So, which stage is this? Okay, so here, my friends, 3C1 is pelvic or para-aortic lymph nodes or both, right? Right? This is 3C. 1 is metastasis to the pelvic lymph node. 2, C2 is metastasis to the para-aortic lymph nodes. Okay? So when you say 3C, 3C is general to the lymph nodes, either pelvic or para-aortic. But since he made it a specific pelvic lymph node, and in the options you have 3C1, so you have to make it specific as well, my friends. Okay? Okay? So again, when I told you, if he is specific in the answer, you also give the specific staging. Option is there. So 3C1. Okay? Few questions on treatment. So in the following scenario, which of these adjuvant therapy option would be the most appropriate? A 59-year-old female that undergone a total laparoscopic hysterectomy and bilateral salpingo-oophorectomy. Final histology was grade 2 endometrial cancer with superficial myo invasion. Okay, so if it is 1 and non-aggressive, well-differentiated tumor. So stage 1, yes, 1A, 3. So for 1A, surgery is enough since it's not aggressive type. Yes, excellent, excellent, excellent. Okay. For the following scenario, which of these questions, this adjuvant therapy option will be the most appropriate? 67-year-old female, she undergone a total abdominal hysterectomy, bilateral salpingo-oophorectomy. The final histology is serous endometrial cancer with parametrial spread. So since there is parametrial spread, this is which stage? Parametrial spread. You know, my friends, that this is stage 3, of course, right? Yes. That the serous type is good or bad. So it's already stage 3B, and to be specific, this is 3B1, of course, okay? And this is even serous type. So this is a high-risk patient. What is the rule for a high-risk patient? What is the rule? Stage 3, already spread happened. Remember, always will be surgery plus combination, right? So the answer here is external beam radiation plus brachy plus chemotherapy, or external beam radiation plus chemotherapy. What do you think? Yes, it's combined, but which one you will choose? External beam radiation. Okay, so you want it to be local and external and chemo. Okay. So dear friends, this will be the last question. I think, mashallah, you are doing really well. Last option, my dear. So here, 66-year-old present to the GP with 2 weeks of bleeding. Last period was at the age 54. Past medical history include chronic hypertension treated with atenolol. She had one child at the age of 28 and BMI of 32. She had 2 weeks wait referral for gynecology outpatient department when she had a bebel biopsy. So you have in the exam to highlight the important stages in the, or the important part when the scenario is long. The result of the later ultrasound and MRI confirm endometrial carcinoma, confined to the endometrium, with less than half of the myometrial invaded. Okay. She is understandably devastated, but keen to discuss management with you. Which of the following would not be suitable first line management? Which stage is this? According to the histological grading, this will be either 1, 1A, 2, yes, or maybe if it's aggressive, it can take 2C. But anyway, what is the main management of stage 1 and 2? Surgery, yes, plus or minus adjuvant, according to the case, right? Okay, so which one is not an option? Here, my friends, remember, they don't ask you about the option of the treatment. They ask you which one cannot be primary. If the patient declines surgery or unfit for surgery, we can treat with primary radio. Hormonal management, I'll tell you, my dear, it has a role in early stage disease, but with higher risk of recurrence, but still, it can be a treatment. No chemo, yes, it's not chemo. Have you ever heard about endometrial cancer treated primarily by a primary chemotherapy? Even when we give chemo, we give the chemo along with the radio as adjuvant therapy, correct? So chemotherapy is the answer because by exclusion, he doesn't want the treatment. He is writing would not be suitable first line management. Okay? Yes, I know it's tricky. I know it's tricky. Okay? But no problem at all, my dear friends. you have managed to answer a wide range of the questions. And I think that you are doing really well with it, right? So well done, everyone. You deserve a little break now. Welcome back, everyone, and let's continue. I would like to go through the important key point from the cervical cancer. Okay, and let's have a look to the surgical management, staging and surgical management according to stage. In the cervical cancer, my friends, there is the modified um, cervical cancer, which is published in the 2021. Okay, it was 2018, and then it is modified and published in the TUG article, right? In the FIGO classification, sorry. Yeah, it is for us, it came as a TUG article, okay? So let's see what is the tracks is there, okay? And what are the things to take care of, okay? When you are revising the cervical cancer. So cervical cancer, my friends, the staging of it. First, you will have to know we have stage 1, and in stage 1, the tumor or the carcinoma is strictly confined to the cervix, and extension to the uterine corpus should be disgraded. So here in 1A, you will find 1A is invasive cancer that diagnosed only by microscopy. So this is almost done after histopathology, like a suspicious lesion, like a case of cervical, screening program. You take a bunch of biopsies, send it to the lab, or even after LITs, send it to the lab. Then they discovered that contain cervical cancer cells. But here, maximum depth of invasion is 5 millimeter or even less. So did he mention anything about horizontal? No. So if I told you that a lesion 7 millimeter with depth of invasion 3 millimeter, which stage is this? It's a 7 millimeter, okay, with depth of invasion 3 millimeter. Which stage is this? Yes, excellent. This is stage 1A1, and I don't care here in the 1A about the horizontal dimension. I only care about depth of invasion. So depth of invasion, if it is 3 millimeter or less, this is 1A1. For 1A2, this is measured stromal invasion more than 3, but up to 5. Okay, so it means like 4 or 5. Okay, so 5, this is a half cm, right? In depth. In 1B, this is invasive cancer, measured as depth invasion more than 5. Okay, more than stage 1A, of course. But here, maximum tumor diameter is important. So what is the maximal tumor diameter? Lesion limited to the cervix uteri with size measured by maximum tumor diameter. In 1B1, the depth of invasion more than 5 millimeter, but depth of stromal invade, the horizontal diameter or the greatest dimension, is 2 cm or less. So if I told you a 2 cm lesion with depth of invasion 7 millimeter, okay, what is this? Stage 2 cm lesion, okay, with depth of invasion 7 millimeter. 2 cm, this is like coin, a good size coin, right? Yes, so this is 1B1. Okay. 1B2 is invasive carcinoma, but more than 2 cm, and or 4 or less in the greatest dimension. So maximum is 4 in the greatest dimension. You see here that they don't care about the depth of invasion anymore from 1B2. So this is a turning point, okay? This is an important landmark. I call it a landmark, okay? Why this landmark is here? This is 1B2, okay? This is very important. It will make difference in our management for the patient and our treatment as well. 1B3. 1B3 is invasive carcinoma, more than 4 cm in the greatest dimension. So you can imagine this is more than 4 cm. This is big, right? Right? It's a big, yeah. In 2, the carcinoma invade beyond the uterus, but had not extended onto the lower third of the vagina. Okay, so upper 2/3 of the vagina are near or far to the cervix? Near. So stage 2, upper 2/3 of the vagina. Stage 3, lower third of the vagina. Remember this one, okay? Very important. When they give you a questions, especially my friends who are studying for the MRCPI, when they give you questions about the staging, they like to play in this area, okay? So please be careful. Even in the last exam in the March 2025, it was there. There was a question about the staging of the cervical cancer. I think it was something like stage 2 or 3. I can't remember exactly, but it was here in this area. Also, my friends, in the MRCOG part 2, last exam, there was a staging questions. Okay, so please, guys, study the staging very well. So, my friends, in 2A, is subdivided to 2A1, 2A2. 2A1 is invasive carcinoma 4 cm or less in greatest dimension. So, what is the difference between this 4 and this 4? Because 4 is there. In 1B2 is 4 also, but in 2A1 is 4 also. But the difference is the spread, okay? Different is the spread, okay? Upper third of the vagina without parametrial involvement, remember, okay? So once vagina is there, upper 2/3 of the vagina, even if the size is 4, now we are in 2A1. More than 4, we are in 2A2. Okay, so please be careful. The tumor is confined to the cervix and uterus or beyond the cervix and uterus and spread to the vagina. Clear, my friends? This is a tricky one and they like this one in the exams. Not every tumor size 4 is a stage 1B2. Look to where the tumor is actually. I hope it's clear. 2A2, invasive carcinoma more than 4 in the greatest dimension. But again, remember the spread. It contained 2/3 of the vagina without parametrial involvement. Once we have parametrial involvement, okay, but not to the pelvic wall, it's 2B. 2B. In stage 3, the spread started to go for the lower third of the vagina and or extend to the pelvic wall and or cause hydronephrosis or non-function kidneys. They like the hydronephrosis stage. In 3A, carcinoma involved the lower third of the vagina with no extension. 3B, extension to the pelvic wall and or hydronephrosis. Which stage they like again? They like 3B in the exam. Hydronephrosis or non-function kidney, but not actual spread to the kidney, okay? In 3C, involvement of pelvic and para-aortic lymph node. C1 is pelvic lymph node metastasis. C2, para-aortic lymph node metastasis. Does that remind you of anything? Dr. Sarah, don't be sad. Just 4 cancers that you need to study. So don't be sad, please. I need you just to try to imagine, okay, in the staging. And there is useful picture we can share as well. But I need you to imagine the staging based on what? Okay, and what are the important point of difference in the staging that make difference in the management? That's very important. Yes, like endometrial. Yes, thank you very much, Dr. Dina. So, 4. Dr. Dina, you take my heart today. Really. Love you so much. So, 4A, 4B. 4 is spread to the adjacent pelvic organ. 4B is distant metastasis. Okay, so simple. Simple, my friends, very simple. I'll tell you what is the important point in the management of the cervical cancer. Cervical cancer, if it's microscopic and local, what is the management of it? You tell me, guys. Small, microscopic, local, microinvasive disease. Conization, especially if there is no lymphovascular invasion. So if this is a stage 1A1, my friend, okay, with very small lesion, 3 cm or less depth of invasion, the action usually conization and it's enough. But if there is lymphovascular invasion, which is actually not common at all in this stage, then we go for hysterectomy. So whenever you have lymphovascular invasion, remember, we will remove everything, okay? In 1A2, standard treatment is hysterectomy. Oh my God, hysterectomy? Yes, hysterectomy. Can be hysterectomy. Remove. Type B radical hysterectomy. Oh my God, why you become very aggressive? Yes, this is to ensure, okay, no spread. So how about the woman who wanted to continue the family? Is there any action for her? Yes. For 1A2, I have action. You know what is the action I can offer her? Radical trachelectomy, right? Sometimes in some centers in low-risk individuals, they can accept conization for with safety margin for A1, for 1A2. But if he asks you in the exam, 1A2 case, old age, no desire of fertility, what is the management? Standard management is surgery. What type of surgery? Radical hysterectomy. Clear? 1A2, and she want to keep the uterus for fertility reason. Trachelectomy, and it's a radical trachelectomy, by the way. Okay, my friends? So, fertility preserving option is very important in the cervical cancer. Do you remember 1B? Yes, there was a spread and the tumor size become bigger. In 1B1, the tumor size was 2 cm in dimension. What is the management for it? Also radical hysterectomy. Here it's type C, but it's radical hysterectomy. For the woman who desire fertility, there is any hope? 1B1, lesion 2 cm or less? Any hope for fertility? Yes, this is the hope of radical trachelectomy. 1B1 still can have fertility sparing option. Yes, actually, Dr. Fatima, this is where we will say, yes, of course, after MDT, this is where we will say in the exam, okay, that fertility treatment option is acceptable for radical trachelectomy. You know, I'll tell you something, okay, and it's written in the TUG article, that some patient maybe with lesion more than 2 can be considered for radical trachelectomy. But this is in some centers, not all centers. This is only after MDT, and they should be aware of the high risk of recurrence. But this is not our choice in the exam. For MRCOG, MRCPI, we are just answering the standard treatment. So fertility sparing option for 1A and 1B1. Okay, friends? From 1B2, here, it is a dilemma to be or not to be. For 1B2, surgery or radiotherapy can be offered to the patient according to the selection criteria, according to the MDT. Okay? If they advise the hysterectomy or surgery or the patient agree for it, it will be radical hysterectomy plus lymphadenectomy, of course. Or otherwise, she can have treatment by radiotherapy. 1B3. Look, my friends, from 1B3 and the coming stages, we start the rule of what? No surgery anymore. Surgery carry more risk of morbidity and mortality. We will start the rule of CCRT. Okay, so 1B3, this is when you start offering the chemo, platinum-based and brachytherapy, concurrent chemo, platinum radiotherapy or CCRT. Okay, this is the preferred treatment in this case, comparable to surgery with less comorbidity and mortality. Okay, so how about stage 2? Where the involvement limited to the upper 2/3 of the vagina without parametrial involvement. Stage 2, again, chemo, CCRT, right? Okay, 2A1. 2A1, do you remember this? It was similar to which stage when 4cm was there, to 1B2. So, as it's similar, 4cm and 4cm, here he told you it's either surgery or radiotherapy. Okay, so that's why even in the TUG article, in the FIGO, they give you the 1B2 or 2A1, both are two sides of the same coin. Okay, but most likely it will be, okay, going for the option of radio. Here, my friend, 2B, CCRT. 3, stage 3, CCRT. Okay, stage 4 is palliative or radiotherapy. And the aim of palliative surgery or radiotherapy, this is to reduce the tumor burden and improve the symptoms. That's it. But the survival is very bad. Okay, friends? You got the point, guys? Asking you in the exam in staging for cervical cancer is very common. Very common. Asking about staging. Asking about fertility sparing option is very common. Okay? And you would remember from 1B2 that this is where surgery rule could be equal to radiotherapy. I can offer the patient either this or that. 1B3 is the start of CCRT. Okay, friends? Understood? Any problem so far? So let's have examples of questions and see if the concepts are clear or not. So a 32-year-old nulliparous woman had a smear showing possible cancer cells. Subsequent to colposcopy, biopsy, and examination under anesthesia, magnetic resonance imaging, all of this for staging, right? And cystoscopy show a lesion confined to the cervix with maximum dimension of 1.8. It has been trying for a pregnancy for the past 6 months. What is the most appropriate option? You tell me, guys, what do you think? What you will do for this case? Maximum dimension 1.8. Anybody can stage this case for me and tell me what is the management? She can have fertility sparing option. Yes. 1B1 or 1B2? 1B1. Okay, so she's eligible for trachelectomy, right? Yes. And if he give you choices between radical, simple trachelectomy, or radical, no, go for radical. Okay? Okay. A 32-year-old nulliparous lady had cancer cells found in a routine smear, subsequent colposcopy, biopsy, and examination under anesthesia, MRI, and cystoscopy, all of this, show a lesion confined to the cervix with maximum dimension of 4.8. She had been trying for a pregnancy for the past 6 months. What is the most appropriate treatment option? Yes, very big, of course. Okay. So, which stage is this? More than 4. Which stage? Okay. So for 3, what you will advise? This is the start of what? It's confined to the cervix, not extension to anywhere. It's the beginning of CCRT. Yes, well done. Well done, my friends. Okay, so you will choose the option with combination of chemo and radiotherapy, okay? Because large size tumor, more than 4, trachelectomy is not an option. Okay, friends, well done. Well done, well done, well done, mashallah. Okay, so I think that you are good, really. Mashallah. So you are doing really well. You don't need me anymore, right? No, guys, you're doing really well, mashallah. So I'm so happy that you have a good basic. Yes, you do really have a good base. So this is reassure me for your exams, inshallah, you will do well. Okay, so I would say سبحانك لا علم لنا إلا ما علمتنا إنك أنت السميع العليم الحكيم. يا رب. يا رب. So my friends, here what we will say. For the ovarian cancer, ovarian cancer is a cancer where we go and remove everything, right? Correct? Yes, we do a full staging laparotomy, correct? Okay, so the question here, if you have early stage of the ovarian cancer, will you add therapy for it? Anyone? What do you think? No? No, 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 no. Okay. So if it's early stage, I don't need, yes, yes, actually, yes. Okay, good. So what about the story of grading in the ovarian cancer? In ovarian cancer, things are more simple. Okay, so they will either tell you that this is high-grade tumor or this is a low-grade tumor, right? Easy. Things are coming very easy with the ovarian cancer, right? Okay, so let's say you have a patient with epithelial tumor, okay, and this patient, she have stage 1. So of course, during the surgery, you are removing everything, right? Stage 2, what you will do for stage 2? Any idea? Anyone? No, stage two. Stage two. You will do the surgery, but you will add a treatment to the surgery, right? So that's why we call it adjuvant therapy, right? So add therapy, this is adjuvant therapy. Okay, so what type of adjuvant therapy we use in the ovarian cancer? Platinum based usually, yes. Okay, how many cycles? Total 6 cycles. Well done, well done, well done, well done. Okay, so for some patient, sometimes starting from stage 2, especially if they have any like poorly differentiated tumor or aggressive tumor, okay, we can even start, okay, with what? We can start with what we call it neoadjuvant chemotherapy, right? So the neoadjuvant chemotherapy, my friends, means that I will give 3 cycles of what? 3 cycles of the chemotherapy again, okay, and then you will go for the surgery, and then what you will go for? You will go for adjuvant. So 3S3 or 3 cycles, surgery, and 3, right? Okay, so this is the summary of the treatment of ovarian cancer. Very easy, believe me. Okay, let's have a staging to the ovarian cancer, looking fast, okay, to the staging and the treatment by stage. So my friends here, okay, for the figure staging, stage 1, where the tumor confined to the ovaries or fallopian tube. Okay, so this is for fallopian tube tumors. For 1A, tumor is limited to 1 ovary. The capsule is intact, okay? Or, not and, or fallopian tube, if we speak about fallopian tube tumor. No tumor on the ovarian fallopian or fallopian surface, no malignant cells in the ascites or peritoneal washing. What is the prognosis of 1A? What do you think? If only tumor limited to 1 ovary and nothing else, capsule intact. Very good, yes. Okay, 1B. 1B is a tumor limited to both ovaries, but the capsules are intact. Okay? No also malignant cells in the ascites or peritoneal wash. Still good. 2 ovaries, yes, but still good. 1C. 1C is tumor limited to 1 or both ovaries or fallopian tubes with any of the following. 1C1 is a surgical spill. 1C2 is capsule ruptured before surgery or tumor on ovarian or fallopian tube surface. 1C is found malignant cells found in ascites or peritoneal washing. Okay? Easy, right? How about stage 2? In stage 2, my friends, one ovary and or fallopian tube and, okay, with implant. So when he tell you in the exam, this is the recall exam in TUG, asking you that the tumor had implant on the tubal surface, fallopian tube surface. So what is this? Which stage is this? 2A, extension and or implant on uterus and or fallopian tubes and or ovaries. Extension to other pelvic intraperitoneal tissue is 2B. What about stage 3? Stage 3, this is tumor involve one or both ovaries or peritoneal cancer with cytologically or histologically confirmed spread to the peritoneum outside the pelvis or metastasis to the retroperitoneal lymph node. So in 3A1, positive retroperitoneal lymph node. Positive retroperitoneal lymph node. According to the size of the metastasis, they have substages of 3A1 to 1 and 2, okay? But remember for 3A1, 3A1, sorry, 1 also, then this will be metastasis up to 10 millimeter in greatest dimension. The second one is metastasis more than 10 millimeter in the greatest dimension. 3A2, microscopic extrapelvic peritoneal involvement with or without positive retroperitoneal lymph node. 3B, macroscopic peritoneal metastasis. So this is the difference between 3A2 and 3B is micro and macro. Peritoneal metastasis beyond the pelvis up to 2 cm in the greatest dimension with or without metastasis to the retroperitoneal lymph node. 3C is macro peritoneal metastasis beyond the pelvic but more than 2 cm in the greatest dimension with or without metastasis to the retroperitoneal lymph node. So it doesn't matter for us, okay? The with or without metastasis to the retroperitoneal lymph node, it doesn't matter to us, okay? When the extension of the tumor to the capsule of liver and spleen without parenchymal involvement. This is their preferred stage in the staging question of the exam. 3C, spread to the capsule, not the parenchyma. Okay? If the spread to the parenchyma, what is this? This is considered as distant metastasis. This is 4B. 4A is pleural effusion with positive cytology. So I think that the ovarian tumor questions or the staging is easier, right? Right? It's very easy in the staging and it's very easy in the summary, of course, you know, of the management, because the management is simply, you know, as we said, depend on the risk. So very early stages, like stage 1A, for example, then no need for a chemotherapy at all or adjuvant therapy. But then we considered from subtype of stage 2, 3, okay, that we go for adjuvant chemotherapy. In advanced disease, and this is some cases of 3 to 4, we will do neoadjuvant, then debulking surgery, then followed by adjuvant chemotherapy, 3S3. Okay, friends. Which stage associated with pleural effusion? 4A, excellent. Which stage to limited to the capsule of spleen or liver? Yes, 3C. As we told, this is the preferred one in the staging of exam. Yes. So my friends, here for the treatment, stage 1, aim of the surgery to complete macroscopic tumor resection of visible disease and adequate surgical staging. Stage 1A and 1B, tumor is grade 1 or 2, then surgery only, and adjuvant chemo is not indicated. Stage 1A or 1B, but aggressive tumor type or poor differentiated tumor or grade 3 tumor, then we can consider the adjuvant platinum-based chemotherapy after surgery. Okay? For stage 1, but non-epithelial cancer in younger age, there is an option of unilateral salpingo-oophorectomy to preserve fertility, especially in younger age, like he tell you 18 years old and she had non-epithelial germ cell tumor. Okay, so in this case, there is an option of fertility sparing, but for epithelial tumor, no fertility sparing option is there. Okay. Stage two with extension to the uterus and fallopian tube, or 2A, 2B, extension to the pelvic intraperitoneal structure. Okay. In stage 3, the first stage with positive lymph nodes, with or without in the retroperitoneal lymph node. So the management here from stage 3, all the stage 3, we will depend on the new adjuvant 3 cycles, then debulking surgery, then 3 cycles. Okay, my friends? Everyone is happy so far? Let's practice some questions. And the questions are easy, very easy with ovarian cancer, believe me. So what is the risk of ovarian cancer in a woman who had RMI of 25 to 250? Yes, 20%. Excellent, excellent. Well done, well done. Regarding fertility sparing surgery in ovarian cancer, select the single best answer below. Those are the 5 options. Which option is correct regarding fertility sparing surgery? So if you know, my friends, I give you a hint. Fertility sparing surgery would be done by midline incision, unilateral salpingo-oophorectomy, and surgical staging. Is accepted standard care in early stage disease. Okay. Biopsy of contralateral normal ovary is not recommended because this may impair the fertility. In advanced stage, chemotherapy is recommended as primary treatment, followed by completion surgery to resect residual masses. My friends, can you see the screen? Can you see what I'm talking about? Okay, good. So what do you think about the fertility sparing surgery? Okay, so in metastatic disease, fertility sparing surgery is not an option, right? Can I treat all the germ cell tumor with fertility sparing surgery, even if it's a advanced stage? No? Yes, okay. So yes, in metastatic ovarian cancer, fertility sparing surgery is not an option. 21-year-old woman seen for a rapidly growing abdominal mass and abdominal pain. Further radiological investigation and the tumor marker panel suggest endodermal sinus tumor. Her case is being discussed by the gynecological oncology MDT. Which of the following is the best management in her case? She's 21, rapidly growing tumor. Endodermal sinus tumor is there. Will you do total abdominal hysterectomy and bilateral salpingo-oophorectomy in this age? No. Radiotherapy? No. surgical exploration, unilateral salpingo-oophorectomy only. We have surgical exploration, unilateral salpingo-oophorectomy with either adjuvant or therapeutic combination chemotherapy. Okay. Yes, so the answer is D. Yes, well done, well done. So Miss Asma, C is okay, but D is better because we use chemotherapy with the fertility sparing option, my dear. Miss Asma is 22-year medical student with right ovarian mass, has been diagnosed with stage 1A choriocarcinoma. Which is the most appropriate surgical treatment option? Very common question in your exam. Very common. Is it laparoscopy or laparotomy? Laparoscopy or laparotomy? Laparotomy, okay. Laparotomy with unilateral or bilateral? Unilateral. So you are here to choose between C and D. Laparotomy plus unilateral salpingo-oophorectomy plus omental or peritoneal biopsy and washing, or laparotomy with unilateral salpingo-oophorectomy with omental peritoneal biopsy and biopsy of the contralateral ovary and washing. No, this is contraindicated. So C. Yes, well done. Well done. Well done, everyone. So, mashallah, you are also knowledgeable for the germ cell tumor. Mrs. Hodgkin, 60-year-old, present with symptoms of an ovarian mass being confirmed on ultrasound. It's a thick cell tumor. What is the most appropriate advice regarding prognosis? So I'm giving you a collection of everything. Look, my friend, for sickle cell tumor, 10% are androgenic. Okay? So that's why people who have sickle cell tumor, what they show as a clinical sign when you're examining a patient with sickle cell tumor and she's old. Yes, of course, hyperandrogenism. That's why 10% are androgenic. Yes. Miss Ivanka, 60-year-old, postmenopausal, nulliparous woman, referred to her general practitioner with sensation of abdominal bloating and complaining that her clothes no longer fit. The general practitioner also found a pelvic mass on examination, referred for urgent assessment for her local district general hospital. She had personal history of endometriosis, but no significant family history. Following your history and examination, you remain suspicious that the woman may have an ovarian tumor. Pelvic scan also confirmed finding. RMI found to be 1,200, very high. What the following option be suitable investigation at this point? RMI, Dr. Dina, okay, is done. So CT, yes, excellent. CT, yes, well done, well done. Okay, so these recommendations are found in the ovarian cancer guideline and also in the postmenopausal ovarian cyst guideline, right? Miss Elisa, who is 65-year-old postmenopausal nulliparous woman, referred by her general practitioner with 6 months of constant sensation of abdominal bloating and indigestion. She tried some herbal and medical treatment with no effect. General practitioner found the pelvic mass on examination, referred for urgent assessment to the local hospital. She had personal history of endometriosis but no significant family history. Following the history and the examination, you remain suspicious that the woman may have an ovarian tumor. Would the following option be suitable investigation at this point? Which of the following investigations are more suitable for women referred to secondary care with suspected ovarian cancer? Pick the single best answer. What is your answer, my friend? Yes, Dr. Fatima. Excellent, Dr. Nahid. Well done, Dr. Dina. Well done, my champion. So I need to calculate the risk of malignancy index. Pelvic ultrasound and serum CA125 are required. Well done, Dr. Mayada, as well. And this is from the NICE guideline of ovarian cancer. The secondary care referral, if the patient did not have already the TVS and CA125, this should be done in the secondary care and calculate the risk of malignancy index before sending to the specialist MDT. Thank you very much, my friends. I think calculating RMI. Okay, so look, my dear, if not already done, here, Dr. Aisha, measure the CA125 and perform ultrasound of abdomen and pelvis. So if you do have this option and you have the option of calculate risk of malignancy index, choose the option which contain testing and ultrasound. Okay. So my dear friends, thank you very much for attending today. Hopefully that our revision for the oncology was a little bit useful in your study. We have tried to give you some tips and tricks for the three cancers, staging and management. Of course, this is not everything, but the questions in the exam are very related to what we have discussed today. They usually don't dig that depth, okay, in the oncology, which is a good thing. They ask you questions for staging, survival rate as well, okay. They ask you about it in a single best answer questions, and they ask you about the main lines of management. But referral pathway, pre-malignant lesions are very important. Okay, so dear friends, have a good day, inshallah, in your revision of the oncology, and hopefully that the staging is not too hard today. Thank you, everyone. Thank you. Barakallahu feekum. Assalamu alaikum.